Good morning, guys. It's Friday morning, and yes, I did just roll out of bed so I can record this lecture for you. Sorry, I'm trying to look at the camera, look at my screen too. Um, so I'm going to get started. I'm going to try to keep this as short as I can, but this is a lot of information to cover, so bear with me. I am going to talk fairly quickly, so this is not 2 hours long. But the great thing is it can be posted online, and then you guys can watch it anytime you want and pause it and take notes and do all that fun stuff. So I'm going to get started and share my screen with you. I'm sorry if I sound a little nasally. I'm sure it's one of y'all that got me snot-nosed. I don't blame you guys. Oh, okay, hold on. Okay. So we're going to talk about valvular, inflammatory, and infectious cardiac and venous disorders. That's a mouthful. That's a lot to cover. Okay. So here's a picture of a cool animation of the heart, and you guys can see the valves opening and closing here, right, as the heart pumps. So obviously the purpose of our different valves that we have here are to prevent, as the blood flows through and this valve closes, it's preventing the blood from back flowing back into the atrium. So the structures here, obviously we have our valves, and then we have, you guys remember seeing that animation on Wednesday where we have the chordae tendineae and the papillary muscles. That's these long muscles right here that are attached to the chamber wall for both the mitral and the tricuspid valve, and that ensures that these valves close tightly. So just remember, as we talk about some of these disorders, sometimes it can be a disorder of whether or not these chordae tendineae or the papillary muscles are functioning properly, because that's that tensile strength that as that pulls down on it, it closes the valve. Just a neat little animation there. Okay, so guys, remember our valves. So we have the right atrium, and then we have the tricuspid valve. Tri means 3, so there's 3 leaflets on this valve. You guys can see what a healthy valve looks like. We've got some nice tissue there that's soft and flexible. Our diseased valves can become hardened. They can have stuff build up on them. They're not nice and soft and flexible, and so when they close, they don't close all the way, or they close improperly. And so we have our right atrium, tricuspid valve, right ventricle, and then we have left atrium, mitral valve, left ventricle, and then we have our aortic valve here that's red, and our pulmonic valve here that is this blue one. So obviously these prevent backflow into the atrium. When blood, or the ventricles, when blood leaves the right ventricle to the pulmonary artery, and then the left ventricle to the aorta. Okay, so let's talk about some key terms. What does stenosis mean? This means that valves are narrowed and can't be opened completely. This can happen for a lot of different reasons. The two most common problems that we have with our valves are stenosis or regurgitation. Damage to the valves can result in obviously abnormal valve function. Stenosis literally means narrowing. So when the heart valves are narrowed or stenotic, they do not fully open, and the passageway for blood to flow through is narrowed. And I've got a really good animation to show you that in just a second. Sometimes the valves, when stenosed, do not open properly. And this allows blood to flow backwards or regurgitate back into the atrium or back into the ventricle. depending on which valve it is. So if we have regurgitation, this can cause the heart to have to work harder to try to pump blood through a smaller opening that's more rigid. So obviously this can stress the heart and cause a lot of problems, right? Stenosis can be the result of a cardiac heart defect. Like we talked about how my son Marshall has a bicuspid valve where he should have 3 leaflets. He only has 2 leaflets. And so right now, as he's young, it's not a problem, but over time, it can become a problem because it can cause regurgitation. And so that's actually a pretty common cause of the regurgitation that a lot of people have is congenital heart disease. It can be a result of a condition like rheumatic fever, and we'll go into more detail on that. But most commonly, the changes for these valves are age-related. We can have calcium deposits build up on the valvular tissue itself, and this can lead to it becoming stiff and not functioning properly. So I'm going to share a different screen with you guys. Okay. Maybe. Okay. Screen share. It's a cool animation that I found on American Heart Association. So when you guys are viewing this, you can come to this website and play around with it. But again, here's our valve. So we have the aortic valve, we have the mitral valve. So here you can see what a nice normal aortic valve looks like. Okay, we got our 3 little leaflets. We've got nice kind of elastic type tissue. And if my internet's going to work properly, I should show you what this looks like. Let's try mitral. Okay, here's mitral valve. So here's what a normal valve looks like. You guys can see as it opens, this is obviously when blood flows through. You can see the little chordae tendineae papillary muscles down there. Nice healthy valve here, okay? This is what can look like when the valve is narrowed or stenosed. So you can see as it's closing, we've got a little bit of a gap here. So this reduces blood flow into the ventricle and then can allow regurgitation, blood to flow backwards. Load. Pretty much same concept, same animation. It's just showing you when that valve is stenosed that it's not flowing properly. Okay, that's a good animation of what it looks like. You know, for the visual folks. Okay, so which term describes the backflow of blood through a heart valve? And the correct answer is regurgitation. So you guys quiz yourself on your key terms, you know, write them on note cards, put your definition on one side and your term on the other, and then go through your note cards and quiz yourself. It's a really good memory trick. Okay, I didn't go too far today. Okay. So let's talk about rheumatic fever, because you remember that we said this could be possibly one of the causes of the valvular disease. So what is rheumatic fever? So it's a autoimmune reaction to a viral infection, and the viral infection is typically strep, a beta hemolytic streptococcal infection, which we all know as strep. This is the same kind of strep that, yes, you do get the strep throat, okay? Strep throat can progress into scarlet fever, and your body will continue to launch an immune response against various tissues within the body to try to combat that strep. And if strep is left untreated, basically the virus, the body continues to attack and will actually attack itself in the process of trying to attack the strep, and then we can have damage to our heart valves, rheumatic fever. So that's why we always say it's important that, if you have strep throat, that you get it treated and you take all your antibiotics, because Streptococcus in general can cause a lot of problems. It can cause some kidney problems as well if left untreated. So if you ever know anybody who has strep, they definitely need to take the full course of antibiotics, or they need to get treated for it. So over the mitral valve, they can develop scar tissue. So you guys can see here, obviously here's what a normal valve looks like, and this is what a rheumatic mitral valve with stenosis looks like. You see how narrow it is. So we're really not getting hardly any blood flow through that valve, which is not a good thing. So these leaflets can actually become fused together. So they have inflammation, and then they just kind of like the tissues just fuse together. And so instead of being these independent leaves that open and close with each heartbeat, they're like stenosed together. So they're not moving. So then you really just do have that very small, narrow opening through which your blood is flowing through. And I promise I think this is the last time I'm going to stop sharing, but I do have a couple really good animation videos that I think are going to help you guys as we progress through this. So I'm sharing my screen with you again.
If repeatedly exposed to group A beta hemolytic streptococcus, though, the body continues to launch immune attacks against the various tissues, but most notably the heart tissue, which can lead to chronic rheumatic heart disease. With chronic rheumatic heart disease, the valves, typically the mitral valve, but sometimes the aortic valve, develop scar tissue from repeated inflammation. The leaflets of the valves become thicker and can actually fuse together, called commissural fusion. Also, the chordae tendinii, which are attached to the valves, can become thickened as well. These changes can cause complication with the valves, most commonly regurgitation, meaning that they don't close all the way. This can progress to stenosis, or narrowing of the opening, sometimes called fish mouth stenosis or buttonhole stenosis.
Sign up for a free trial today and watch the full video on osmosis.org.
Okay, so that, like I said, that was a really brief animation, but a pretty good one that kind of shows what happens to those valves with rheumatic fever. So when they fuse together, it's called commissural fusion. I'm like, that just sounds like like it's a miserable thing. I kind of like that word, but anyways, these people can have lots of problems with this, right? So it's commonly occurs on the mitral valve. So if we have mitral valve prolapse, now we're moving into another concept here. Like I said, I'm going to go quickly. This is the most common of all of our heart valve diseases is our mitral valve prolapse. Normally when the flaps of the mitral valve remain closed, these don't, they prolapse back in to the atrium. Okay. They bulge backwards like a parachute when the ventricles contract. So this can happen when either maybe one flap is too large, or if there's a defect, member in those chordae tendinae, those little things that secure to the wall when the valve opens. Also, the bulging flaps can have a defect of not fitting together. So when the valves close, it doesn't close all the way. and blood can, obviously backflow into the left atrium, which would be mitral regurgitation. So the etiology or causes are, they're either unknown. It can be hereditary, passed down, just a defect in those leaflets of the heart. It's common in women, usually diagnosed between ages 15 to 30. Infection, ischemic heart disease, and enlargement of the heart can all cause this. So again, here's one more video, and as we kind of get through this stuff, I'm going to share my screen with you. Sorry. Okay. Here's another animation. Again, you guys can go to this website and play around with it. It's really cool. It has all these animations of the heart. So obviously, here we go. We've got our valve. It's opening, it's closing. We have blood flowing through. Here's what prolapse looks like. Okay, so you can see these valves here, they open and close normally. They're not moving up and back. And with prolapse, you see how they do kind of look like parachutes. They're just, they're forcing back up into that atrium as they close. They're like bulging. And then we can have a complication along with that of regurgitation. So see how as it's closing, some of that blood is back flowing into that atrium. And then look here, you can see it all side by side. So here's normal. Here's that bulging prolapse. And here's that where it's allowing the regurgitation or the blood to go back through. So the valve leaflets don't close properly, and this is forcing blood back into the atrium. So like I said, some really cool animations on this. You guys can get in there and play around with it, because I think when you're visually engaged and you can kind of see that in your mind, it makes a little more sense when you're trying to apply it to like your patients and the signs and symptoms they're going to experience. It just kind of helps make more sense, at least to me. Okay, so what are our signs and symptoms that our patients are going to experience with this? Most patients are actually asymptomatic. They don't know they have this until it's way later become a problem, right? They can have anxiety, atypical chest pain, dizziness. It can cause arrhythmias, dyspnea, and fatigue. And this is just all related to just improper or decreased cardiac output because of the regurgitation. So we're just not getting enough of that blood pumped out of the heart because the valve's not functioning properly, so it's not pushing it forward, and we're having the regurgitation. So when they do develop these symptoms, as the regurgitation can become more severe and pronounced, then they can have these symptoms. And like I said, these symptoms are really secondary to that decreased cardiac output that the patients are experiencing. Complications are usually pretty rare, but they can have the arrhythmias. We can have embolus. So as we have regurgitation, we can have clots that form. Your most common one is going to be your heart failure. So as we have that regurgitation and that pressure buildup in the atrium, in the ventricles, it can stretch out the walls of the ventricle, and they just become loose, and that muscle just becomes not as strong. Like I compared it to like a stretched out bathing suit. You first day you buy that bathing suit, it's nice and tight, and that elastic is like holding it all in. And then after you've worn it all summer and you put it on, that last time you go swimming, it's not as tight. The fibers aren't as tight, and it just doesn't hold you in like it did at the beginning of the summer, right? This is kind of what happens to your heart during heart failure. It's just not as tight. It's stretched out. And so it's having to work a little bit harder to hold it in or to get the blood out. So I just think that's a good visual. So how do we diagnose this? What are some diagnostic tests? Well, the first thing we might hear on our patient, which is part of a nursing assessment or a physician might hear, is a murmur. And we talked about this in our previous lecture. So remember that murmur is that swishing sound that we will hear, and this is caused by that blood leaking back through those valves. So you'll hear it as a swishing sound. So we want to auscultate for a murmur or a click, obviously when we're listening to our heart sounds. And then definitive diagnosis is going to be that echocardiogram with the Doppler ultrasound, like I showed you guys in that video on Wednesday. So these are the structures of the hearts that we can really visualize with that echocardiogram to get a diagnosis of this. Therapeutic interventions, none. We really don't do any therapeutic interventions. We treat the symptoms unless it becomes so severe that they are not perfusing at all, which in some extreme cases that can happen. So some things that our patients can do is obviously a healthy lifestyle, avoidance of stimulants and caffeine, stress management. If their heart is trying to compensate by beating faster, we can put them on beta blockers for tachycardia, or treat arrhythmias that they have. We can put them on an aspirin or an anticoagulant to prevent embolus or thrombus forming. And then, like I said, in those extreme cases, we can do valve surgery for the severe mitral valve prolapse. And this would be a valve replacement, and we'll talk about that later on. So a nurse is caring for a client diagnosed with mitral valve prolapse who is asymptomatic. What does the nurse expect to be ordered for this client? So the answer is actually no treatment is required when our patients are asymptomatic with this. If symptoms develop, then management is aimed at symptom control. Okay, let's talk about mitral stenosis. So we talked about mitral valve prolapse. Now let's talk about stenosis. So the pathophysiology behind this is that we have thickening of the mitral valve. We have these flaps here. The chordae tendineae can become shortened, and this is causes narrowing of this opening right here. See how this one's nice and wide and open, and this one's really narrow. This obviously our blood flow is obstructed from the left atrium, and then the left atrium can become enlarged because it's holding extra blood volume because of the obstruction. So just think if you're trying to push water through a hose and you have it real narrow right here, right? Let's say we have a water hose, it's really narrow, and we're pushing it into a balloon, right? And so the water can't, we've got pressure building up down here in the balloon because it just keeps holding more and more and more and more water. It's expanding because the water can't escape, right? So that's pretty much is what's happening here. So as we're really narrowed and then we're pushing that blood through, the left atrium is enlarging because it's holding extra blood volume caused by the obstruction. Backward pressure can also occur in the left atrium. So backing up the regurgitation can increase pressure in the lungs as well, and can eventually cause the right ventricle to dilate. So it can become severe that it will not only affect the left ventricle, but the right ventricle and our pulmonary circulation as well. So rheumatic fever is a very common cause of this mitral valve stenosis. Okay, congenital defects, tumors, rheumatoid arthritis, but rheumatic fever and your congenital defects are your most common causes. Signs and symptoms, we can hear a click or a low-pitched murmur. This may or may not be heard depending on the severity of it. Your patients will usually say that they don't have any signs and symptoms, like I said, until it gets severe enough that we're having that heart failure issues. Because a lot of people, I mean, just like I said, like my son has this mitral valve. Well, he's not going to know at 2 years old or 3 years old, but when he gets 80, that wear and tear on the heart can start to manifest itself after all those years, right? Because, it's had to work so hard. So a lot of people, don't know they have it. It gets physician or a clinician may or may not hear a murmur on examination. That's usually how it first gets discovered, is somebody will listen to him and go, oh, you know what, I think I hear a murmur. Did you know you had a murmur? Have you been ever told you've had a murmur? Well, let's look into that. And so they maybe, then do an echocardiogram and find out that they have this. But it's not usually because people come in seeking symptoms for treatment, because that usually occurs later on in life when symptoms are very severe. So, but they may report as those symptoms get severe. Again, the fatigue, shortness of breath with activity. They can even have dizziness and fainting. And again, this is a result of that decreased cardiac output. So just think with these valvular disorders, we're just not getting the blood flow like out of the heart to the body like we need to. So their symptoms are all going to be a result of that decreased cardiac output and that decreased blood flow. The body's just not getting the oxygen and the blood flow like we need to. Complications are very similar to our previous valvular disorder. We can have the blood clots, we can have heart failure, we can have a stroke. That's the blood can pool in the left atrium from the backflow, and then it coagulates and congeals, and then it can pass through a valve at some point and lead to a stroke. There's my dog. The patient can have seizures, just all kinds of weird things at the end when it's more pronounced. So diagnosis, obviously patient history, physical exam, and then diagnostic tests. We may see even patients develop arrhythmias later on as their heart failure. If they have heart failure and that progresses, we may see a very common one called atrial fibrillation. We may see an x-ray that might show enlargement of the heart. Maybe they just go in for an x-ray, shortness of breath or something, and they do an x-ray and it shows enlargement of the heart. We might need to look into that further with like an echo Doppler ultrasound. That's our gold standard for evaluation of these valvular diseases. But sometimes it gets detected and picked up on other ways that we have a way to suspect that something's not right. So therapeutic interventions, when the patient's asymptomatic, obviously no treatment's needed, just like with our previous valvular disorder. So just like with the mitral valve prolapse, anticoagulants can be given to prevent emboli from that stasis of the blood in the atrium. If they do develop arrhythmias like atrial fibrillation or irregular heart rhythms, we would treat that, with our antiarrhythmic medications. If invasive treatment is needed, they can do what's called a valvuloplasty, which I'll show you a picture on the next slide. And that's when you can go in with a balloon, kind of like on that video I showed you where they did the balloon to open up that narrowed artery. They can basically go in and try to open up that narrowed or stenosed valve with a balloon. And then surgical treatment is, again, valvular repair, if needed, a valve replacement. And here's a picture of the balloon. They'll thread this balloon in through that valve and inflate it and see if they can try to get it from being, narrow to being wider. Narrow, wide, okay. So when they have the balloon valvuloplasty, we keep them in the hospital. We'll monitor them for heart failure, embolus, assess our heart sounds. It's really kind of the same because they're going to go in through that femoral artery to thread this up and through. And so you would treat it like those cardiac cath patients where, they're bed rest, they don't move, we hold pressure on that site. Very similar process and procedure as far as nursing care for a patient who's had valvuloplasty. And then we have the surgery, which could be the commissurotomy. So remember, when those valves fuse together, they can go in and try to, separate the valves again, or that just a full-on mitral valve replacement. My grandfather actually had rheumatic heart disease as a child and had to have valve replacement. And he had an artificial valve, and I used to always remember every time I was a little girl and I'd go give him a hug, because he didn't have he had a artificial valve, not a like a bovine valve, or we'll talk about different types of valves. But I'd go give him a hug and I'd put my head on his chest and you could just hear a mechanical valve. It just click, 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 click with every heartbeat. I used to think that was so cool when I was a little girl, but my grandfather had a mechanical heart valve. Aortic stenosis. So obviously this is very similar to our mitral stenosis. It's just on the aortic valve, okay? So obviously we know our aorta is that main artery that carries blood to our body. When this is narrowed, we can have backflow of blood into the left ventricle. This aorta can become narrowed from again, the rheumatic heart disease, those calcifications that can happen on the leaflets with aging, those congenital heart defects. The common causes are kind of all the same on these valve disorders as well. Again, we can have the stretching of the ventricle because it's not getting all the blood out like it needs to, and so the ventricle stretches and becomes hypertrophied. So again, knowing those terms, hypertrophy means enlargement. So it becomes hypertrophied, and we have this large stretched out ventricle, and so at that point it's progressed into heart failure. And then we have decreased cardiac output. Again, very similar with the other valve, just in a different location. So again, you may have no signs and symptoms for many years. Some early signs and symptoms may be dizziness, syncope, that activity intolerance. Those are all those signs and symptoms of decreased cardiac output. And then our late symptoms that we can have is chest pain. And then we start to exhibit those signs of heart failure, so we can start to have the edema build up, fatigue, the orthopnea. You guys remember what that means? That means I can't lay flat. I can't breathe when I lay flat. Okay, so those signs of heart failure can occur in our patients. And then complications, obviously we talked about the heart failure, we can have arrhythmias, we can have blood clots build up, and then we can have sudden cardiac death with this one as well. It's more common because we have, we're trying to push that blood out that main artery. So this one's a little more of a serious complication. So our therapeutic interventions, we can put patients on vasodilators just to help with blood flow. We can put them on antiarrhythmics, so like digitalis. And we can also treat the heart failure. So we might put them on a medication that will slow the heart rate down and help it relax. And then you guys remember digitalis slows the heart rate down and increases the contractility of the heart. So we have a slower heart rate and a more forceful contraction to try to help get that blood out where it needs to go. We can treat the heart failure, obviously, with diuretics and other medications like beta blockers. And then if surgical treatment is needed, it would be that aortic valve replacement. Okay. And here's another picture. Obviously, you can see what this healthy aortic valve looks like and what this stenosed one looks like, right? Okay, so what signs and symptoms in a patient with aortic stenosis indicate to the nurse severe obstruction in blood flow to the myocardium? So what's myocardium? If you don't know that, that's the muscle of the heart. So what do you think? Okay. So the answer to this would be that exertional dyspnea and arrhythmias, okay? So think about blood flow and perfusion, and when we don't get blood flow and perfusion, we can have shortness of breath because we're not getting enough oxygen, and then we can have arrhythmias because our heart tissue is not getting enough oxygen, okay? So aortic stenosis, severe blood flow obstruction, we're going to have shortness of breath, and we're going to have arrhythmias. Calf pain and fever really don't have anything to do with that. Okay. All right. So the nursing process when we're caring for patients with these valvular disorders, we need to get a thorough health history. Have they ever had, untreated strep infections? Do they know of a history of rheumatic fever, endocarditis, cardiac disease, congenital heart defects, either in them and or their immediate family? Table 23.2 shows some data collection for your patients with cardiac valvular disorders. So I would just familiarize yourself with that. Just give it a look over. When we're doing our assessment, respiratory wise, we want to listen for signs of heart failure. So we may hear crackles that indicate pulmonary edema with heart failure. And then, our patients may report that exertional dyspnea when they're trying to get up and move around. Cardio assessment, we may hear murmurs or an extra heart sound. We may observe arrhythmias if they're on a telemetry or we're doing EKGs. We may see edema to the lower extremities or that jugular vein distension. These would also, all be secondary to the heart failure they can experience because of this. And then remember those signs and symptoms in our skin. We can have the clubbing on our fingers from poor oxygenation, cyanosis, cool, clammy skin. These are all circulatory manifestations of low oxygenation. So what are some pain relief interventions? Obviously, we can provide rest between activities. Slow pacing of the care can allow a patient extra time to perform their activities. So they may not be able to just get up and have their regular morning routine like they've always done. We may have to do some, take a rest, do some more, take a rest. So that's really big for these patients. They can get everything done, just maybe not the manner they were used to doing it before, have to slow down and take rests. Nitroglycerin can sometimes be used if they are having decreased cardiac perfusion and they're having chest pain with that. So obviously nitroglycerin is that vasodilator that opens up those coronary arteries and helps the heart tissue to get more blood flow. So normal cardiac function, obviously we want to take a full set of vitals. We want to get a blood pressure and a pulse. We want to assess whether that pulse is regular or irregular, right? That's important to note. We want to do an intake and output because this is important to monitor for our fluid status. We want to get daily weights. And with these heart failure patients, daily weights are very, very important. They need to report 2 to 3 pounds of weight gain in 24 hours or more than 5 pounds in a week to their doctor immediately. We'll talk about that when we get into the heart failure chapter as well. Sodium restriction, so this will decrease the amount of extra retained fluid that the heart has to work hard to push around, right? So less sodium is better for us with these patients. So we want to, and then give our medications as ordered. Okay. All right. So mitral valve replacement, I'm not going to go into huge detail on this surgery, but I just thought how cool this looks. Like, look at this picture. Someone's valve wide open, got your chordae tendineae here. It just looks pretty dang cool. So the types of repairs that we have are, remember, that commissurotomies. They can go in and separate the fusion of the leaflets or the actual replacement of the valve itself. Anybody who has a valve replacement is going to require long-term use of anticoagulants. So they're always going to have to be on a blood thinner as it flows through that artificial, either a mechanical valve or a like a bovine valve. So they're always going to have to be on an anticoagulant for the rest of their life. Okay. There's the different types of valves that we have: the pig, cow, human, self. So there's different valves that they can get. Cultural considerations, obviously somebody may not want a pig or a cow valve. They may have some kind of religious practices that we know would not allow that. Again, they're on that lifelong anticoagulation. with the mechanical valve, but not with these biological valves. Okay, so there's benefits to these, and these would be used for your older adults. The problem with these is, though, they can develop problems just like our valves, right? Because they're valves. So they can have degenerative changes and calcifications over time, just like our own valves. The mechanical valves require the anticoagulation, and these do not. So those are the main ways that we can treat that with valve replacement. Teaching prior to surgery. Anytime someone's going into surgery, we need to teach. This is a major surgery, and they'll usually wake up 24 to 48 hours in the ICU, and they're going to need a lot of teaching beforehand on what to expect, right? Pain management, they're going to, be on a ventilator for 24 to 48 hours. They're probably going to wake up with chest tubes. I mean, this is a major cardiac surgery, so the more that we can teach them about it to prepare, the better. And then post-operatively, obviously, we want to provide pain relief. They're going to be in an ICU setting. They're going to have, obviously, dressings, a chest tube, probably an NG tube while they're in PO for a while, IVs, possibly arterial lines. It's important for us to assess their pain, their lung and their heart sounds, their cardiac arrhythmias. We want to assess the chest for crepitus, because when they open up that chest, they can have sub-Q air leak into that sub-Q tissue. And we want to keep the patient warm after surgery, so they might use warm blankets or the bear hugger, because when a patient is cold and they shiver, this increases our oxygen demand to the heart. And they can also give them paralytic agents to eliminate shivering as well. Okay. So a client who has undergone a valve replacement with a mechanical valve prosthesis is due to be discharged home. During discharge teaching, the nurse should discuss the importance of antibiotic prophylaxis prior to which of the following? Dental procedures. Oops, sorry, went too far back. So you guys remember how we talked about these people who have these heart valve issues need to have antibiotics before they have any kind of invasive procedure and before they have dental procedures, because the bacteria can enter from our gums into our bloodstream when we have dental cleanings and things like that, any kind of dental work. And so we have to treat these people prophylactically with antibiotics, or they can develop endocarditis, infected endocarditis, which we're going to talk about very soon in this slideshow. And I know we talked about this in our surgical chapter, so you guys should have this down by now, right? Because there was a very similar test on your surgery chapter, and it said which type of med would we give to this patient with a valve disorder before surgery, and the answer was antibiotics. So it's kind of a similar question, but it's just saying when would we give antibiotics, and this would be before a dental procedure, so any kind of invasive procedure. Okay. The nurse is caring for a client to schedule to undergo mechanical valve replacement. Client education should conclude which of the following? So our mechanical valve is going to necessitate the long-term use of required anticoagulants. Okay, they're going to be on those anticoagulants for the rest of their life. All right. A client with aortic stenosis is reluctant to have valve replacement surgery. A nurse is present when the healthcare provider talks to the client about treatment that is less invasive than surgery, which will likely relieve some of their symptoms. What treatment option do you think may have been discussed? Remember that balloon valvuloplasty, so they can stick that balloon up in that valve and open it up. Okay, so that's a less invasive surgery for the patient. All right, Moving on from valvular disorders to infectious endocarditis. If Mrs. McPherson is going to give you guys a break, now would be an excellent time for her to come in and press pause on this video. So I'm going to give her a few seconds to do that. She can always rewind and backtrack if she needs to. So I'm going to continue on with my slideshow. So let's talk about the layers of the heart. We have the endocardium. We kind of already talked about this later, but this is our inner layer that lines the chambers of the heart and our valves. And then we have our pericardium. We have our pericardial sac. We have that serous layer in between where we have some fluid that prevents that friction when our heart beats, right? Okay. So let's talk about infective endocarditis. So this is infection of the endocardium. Where's our endocardium? It lines our chambers and our valves, right? Okay. So pathophysiology, we have an invading organism that attaches on that endocardium. This can cause vegetative lesions. What does that mean? It means basically we just get some, have you ever seen like barnacles like on a ship? That's kind of what it reminds me of. We just get these like calcifications, these vegetative lesions that develop on the valve leaflets. So the etiology, entry of organism into the bloodstream, risk factors, immunocompromised, artificial heart valves, congenital or valvular heart disease, IV drug use, and gingival disease. I have no notes on any of this. Oh. Hold on, give me a second. It's not showing any of my notes. I'm going to stop share for a second and I'm going to pause this. Give me 1 second. Okay. I had the wrong PowerPoint, so I had to pull that back up. All right, so I was like, I know I had a picture on here. All right. Okay, so endocarditis, infective endocarditis is infecting the lining of the inside of the heart chambers and valves. This occurs when the heart with in hearts with artificial or damaged valves or pacemakers. Men develop infective endocarditis more than women, as do older adults compared to younger adults. Healthy hearts are usually resistant to this infection. Bacteria do not easily adhere to the intact surfaces of the endocardium. So if we have somewhere, somehow, the endocardium has been damaged or not intact in some way, then the bacteria can settle on those areas that are not intact or damaged. So caused by bacteria and an abnormality of the endocardium. So you're going to have kind of those two processes that come together, like a congenital heart defect, a prosthetic valve, a valve disorder like our mitral valve disorder, rheumatic heart disease, or other intracardiac devices like a pacemaker, a history of IV drug use. Normal flora in the mouth can enter the bloodstream with our dental procedures or when our gums are damaged, or any infection that we get systemically throughout our body can, as the bacteria, is in our blood and we're trying to fight off that infection, but these bacteria can settle into those places that we have defects in our heart, and then it can cause all this bad stuff. So strep endocarditis results in this large vegetation. You can see it right here. Here's a close-up view. This is the mitral valve. And then it can obviously cause lots of problems, right? Bacteria can come from distant infected sites, like I said, in our body where we have any kind of infections. It could be like a UTI. Strep and staph are your most common bacterial culprits in this endocarditis. And again, invasive dental procedures as well. Okay. So what are some manifestations? They can cause the vegetation. So there's basically clumps of like pus and nastiness, and then the valves won't open and close properly, which can lead to heart failure. Most common are the mitral and aortic valves. It can cause the regurgitation. So we may hear a murmur when we auscultate. These vegetations or the clumps of this bacteria and pus can break free and cause embolus. So obviously not a clot of blood, but a clot of like bacteria and pus and nastiness can break off and block the arteries on the left side, will travel to the lungs and cause pulmonary embolisms of pus and nastiness. Can lead to cardiac conduction problems, blocking of the SA nodes, firing. So signs and symptoms that we might see: fever, obviously. We got nasty pus on our heart, fever, right? Chills, those signs and symptoms of infection. Fatigue, and so signs and symptoms of infection mixed with signs and symptoms of our valvular disorders. So think those two together. So fever, chills, plus that fatigue, that cough, that edema, those signs of decreased cardiac output. Those tiny emboli of like bacteria and pus that can break off, they can travel to other parts of the body. So the skin. So right here you can see these are called ocellular nodes. And you can see them on the fingers and on the feet, these Janeway lesions. So you can see they have these weird like skin manifestations. It can go under the nail beds. They call this a splinter hemorrhage. We can have hemorrhage in the conjunctiva here. So these are just some weird manifestations that as those bacterial clumps break off and get into our blood circulation, it could just cause these really crazy manifestations. Okay, so how do we diagnose this? We would take blood cultures. We want to properly identify the organism so that we could treat it. We would use an echocardiogram to help us visualize the valves and show vegetations, find out which valve it is. So these people are going to need to be hospitalized and be on very high doses of antibiotics for a prolonged period of time, because it's not going to just go away overnight. We have like nasty pus going on in the heart, and it's gross. Okay. It's usually going to take anywhere from 2 to 8 weeks of IV antibiotics. So once they're stable and they're fever-free, they can be discharged home and do antibiotics on an outpatient basis. Surgical repair of the valve may need to be done in some severe cases. Prevention is really important. So we want to do teaching for our patients that, if they do have any of these previous things that can cause this, which we said were what? The heart, valvular diseases, prosthetic valves, valve disorders, everything like that. They definitely need the prophylactic antibiotics prior to any kind of procedure. And they also need to report any fever or infection to their physician. Okay, because even just a UTI, when they get a UTI, it can progress into this bacterial or infective endocarditis, right? If we do have a patient teaching, also part of the patient teaching, needs to be how to prevent that trauma to the gums where the flora can enter into the bloodstream, or normal mouth flora. So we want to tell them they want to brush with a soft bristle toothbrush so that we don't have the gum damage. So we don't want like a really hard bristle toothbrush that's going to make their gums bleed, and then bacteria can get in. So they want that nice soft bristle toothbrush so they're not causing any damage to their gums, and they need to get annual cleanings at the dentist. It's very important. Their dental hygiene is very important to prevent this. But again, they will need those prophylactic antibiotics before they have their cleanings. Here comes a child. I need to pause this. Okay. If you see a child running across my living room, I apologize. I tried to get this done before they woke up. Okay. So where was I at? Good skin care, hand washing, etc. All the things we would do to prevent just normal infection from our day to day are obviously important for these people who have, like heart valve problems and things like that to prevent this from occurring. And then obviously, like I said, they want to report any kind of symptoms, fever, chills, sweats to their doctor right away. Pericarditis is inflammation of the pericardium. This can be acute or chronic. They can have ventricles filling reduced. Hold on. I guess I didn't talk a lot about this in my slideshow. Basically, it's inflammation of the pericardium, and we can have decreased cardiac output and decreased blood pressure because that sac around the heart gets so full of fluid that it can't pump properly. It basically compresses the heart muscle. Okay. So, which of these should a nurse reinforce in the discharge teaching with a patient with endocarditis? Have the biannual dental cleanings. And that's important that we focus on that dental health, right? Okay. So acute pericarditis, this is inflammation of the pericardium. That's that sac that surrounds the heart. It's full of fluid. The inflammation creates a problem for the heart as it tries to expand and fill. So if the heart cannot expand, we have a problem because then the ventricles, our heart contracts, expands to fill up, contracts, pushes the blood out, expands to fill up. So if we can't expand out, then we're not filling up and then we're not pumping out much, right? We just have really decreased cardiac output because if the sac around the heart is squeezing on it, then we really just can't get much out, right? So it's a problem. We have decreased cardiac output. So we're going to have, EKG rhythm changes. It's not good. It can be caused by a variety of factors, including Lyme disease, reactions to medications, connective tissue disorders, Dressler syndrome. I don't expect you guys to know all those etiologies, but those are just some of them. So signs and symptoms obviously is going to be chest pain because that's going to be painful because it's all inflamed around your heart, right? So we can have substernal radiating pain, it's a grating. And then when you listen to the heart, you can hear a pericardial friction rub. So as you listen, it sounds like because you can hear the heart like rubbing against that pericardial sac. It can have dyspnea, cough, low-grade fever with this as well. And the thing that differentiates this chest pain from like an MI chest pain is that the pain is worse when they take a deep breath. So obviously when they're taking deep breath, that's pushing the heart against that sac, and it's causing that pain because it's inflamed. So if you have someone that they say they have chest pain and it's worse when they take a deep breath, that's a red flag for pericarditis, right? Basically anything that increases the pressure in the chest. So when I take a deep breath or maybe when I cough, it hurts worse, my chest pain hurts worse. Those are all red flags for pericarditis. So complications, infection can cause fluid to accumulate in the pericardial cavity. This is known as a pericardial effusion, which can lead to a life-threatening cardiac shock known as cardiac tamponade. So signs and symptoms of this would be those decreased circulation. So we have low blood pressure, confusion. So our blood pressure drops, our heart rate goes up, which is tachycardia. So hypotension, tachycardia, we start having just decreased oxygenation. So those signs of early decreased oxygenation, confusion, restlessness, and then would progress into obviously shock if left untreated. So the procedure for this is a pericardiocentesis, and that is where they go in with a needle into that pericardial sac and they relieve the fluid, right? They aspirate that fluid out, draw off that excess fluid to relieve the pressure and allow the heart to expand and refill. So risks include bleeding, obviously puncturing the lung, because we're just kind of, we're going in with a needle right there, right? It's kind of right there close to it, or a laceration of the heart, it's a real thin line there between the pericardial sac and the heart muscle. So we could accidentally, cut the heart muscle. So they trained, skilled people, right? But there are always risks involved. And then other treatments and non-emergency is antibiotics. We want to put these people on bed rest to decrease the heart workload of the heart during this acute stage. Non-steroidal anti-inflammatory drugs used to treat the inflammation, and corticosteroids used to treat the inflammation. So like Solu-Medrol IV, or like NSAIDs like Motrin and things like that to decrease inflammation. We're almost done. Bear with me, guys. Myocarditis, inflammation of the myocardium. Our myocardium is our actual muscle of the heart. This is a rare condition and is most commonly after a viral infection. Symptoms can range from asymptomatic to severe cardiac symptoms, like fever, fatigue, palpitations, chest pain. We're obviously going to treat the cause of the bacteria. We're going to treat it for infection. We're going to reduce the workload of the heart by putting the patient on bed rest, and treat those symptoms of heart failure. So put them on a diuretic, an ACE inhibitor, beta blockers. So our nursing interventions would be to reduce fatigue, frequent rest periods, energy conservation, put these people on bed rest. It's going to rest that heart muscle. So here's a little table I put in here for you guys so you can go back and look at. It's just the disease, signs and symptoms side by side, which sometimes helps to see it like that. So cardiomyopathy, or enlargement of the heart. This is enlargement of the heart muscle that leads to ineffective pumping of the blood. So we have dilated and hypertrophic. There's other kinds, but those are the two I'm going to talk to you guys about. Those two I think you need to know out of the cardiomyopathies. So the dilated is the size of the heart chambers increase and the walls of the heart become thin. So we have big chambers, thin walls. Okay. This makes the walls weaker, and so our cardiac output is reduced because we have just like really thin walls here, thin muscle walls. So they just can't push out as much blood because they're thin. What can cause this? Poorly controlled hypertension and coronary artery disease, and also those people who use cocaine. So cocaine's not good for you. And then our hypertrophic cardiomyopathy, this can be a hereditary disorder, and this is caused thickening or enlarging. Hypertrophy means enlarging of this cardiac muscle wall, right? And this actually causes it to become rigid, so it thickens and it gets hard. So it's not like a muscle that, expands and contracts. It just becomes kind of hard and stiff. So it doesn't completely fill the ventricles with each pump. And so obviously then we're going to have decreased cardiac output with this as well. So those signs and symptoms of decreased cardiac output, fatigue, dyspnea, with physical exertion are going to be main symptoms here. We can have those signs and symptoms of heart failure, so the edema, the swelling in the ankles and the feet, with the jugular vein distension in the neck, dizziness, lightheadedness, dyspnea with exertion, poor physical activity tolerance, heart arrhythmias can develop, chest pain, those very similar symptoms that we talked about with all of these that basically can lead to heart failure. Therapeutic interventions, there's no cure. We just have to treat the symptoms. So we can put the patient on anticoagulants to help prevent blood clots, and then treat the heart failure. Okay. DVTs, thrombophlebitis. So thrombophlebitis is formation of a clot followed by inflammation within the vein. Made of a mass of platelets and fibrin. It's the most common disorder of the vein. It can occur in superficial and deep veins in the body. Most commonly, it occurs in the legs, thigh, and pelvis. Sorry, I'm going to pause this for